Lopke, can you please tell us how we need to detect recurrence after endoscopic resection?
Thank you very much, Thomas. I will try and do my best so that everybody feels very comfortable detecting recurrences after EMR. I have no disclosures. Firstly, this is a very busy slide, I recognize that, but what we want to know, is recurrence a problem? Well, it sure is. 16% will recur after 4 months, 4% after 16 months. Risk factors for that are larger lesion size, use of APC to ablate adenoma, and intraprocedural bleeding. However, recurrent adenoma was usually diminutive, unifocal, and can be treated endoscopically in 93% of cases. So if the initial EMR was deemed successful and there was no submucosal invasion, 98% of people were adenoma-free and had avoided surgery at 16 months following EMR. Can we predict recurrence? This slide's been shown before. Yes, we can with the Sydney EMR recurrence tool. We can nicely see that lesion size, intraprocedural bleeding, high-grade dysplasia will give us a score and will predict us risk of recurrence. So indeed, we have published a standardized imaging protocol for detection of adenoma recurrence, and we can actually see that we can achieve a very high negative predictive value if we combine both high definition white light and NBI, if we both apply it to the scar. So how do we do this? We first start with high-definition white light. We go over the edges, and then if it's a rather round scar, we then carefully inspect the center of the scar, and then you perform the same routine with NBI. You really want to search for a transition point where you can see that a non-neoplastic pattern turns into a neoplastic one. So this transition point really is the key, and it's really, it's most of the times visible under white light, but we do need the NBI as well to detect flat recurrences at first glance. Here at the anorectal junction, you can see very nice very large scar under white light and NBI. Here again, and again, very nice, all without recurrence, all very nicely seen with the both techniques. But here, it's actually, you don't even need glasses to see this one. Very big recurrence. But this one's much more subtle. If you look at the left-hand side, white light will actually really not reveal the recurrence very easily. But if you look under NBI, you can really see there's a tiny focus of recurrence right here that you will want to remove. Here again, rather elevated recurrence, not so hard to distinguish, but you do see the scar here, and in the middle, you see a rather large recurrence, even better to be seen under virtual chromoendoscopy. Same here, see it. That's why you see the scope position is almost longitudinal to the fold, just so you can see the complete scar, so you wouldn't miss any bits of it, because if you would look in forward view, you might just see one side of the fold and miss the bit of recurrence which is at the back. And here again, a nice scar with actually 2 foci of recurrence. And again, I think I asked David, should I put this many slides in of recurrence? He said repetition is key.
Got a question regarding treatment of recurrence. Obviously, we are not seeing any recurrence and not doing a treatment, but during the presentation, You mentioned that resecting with a biopsy forceps or even a snare, and then applying soft coagulation on the defect. I just wonder how safe it is to do soft coagulation in defect, or is it much safer because of the fibrotic area underneath?
Yeah, you may have heard before that, for example, snare tip soft coagulation on the margin of the defect after piecemeal EMR, you would not do without having injected that margin, right? Mm-hmm. So that is not safe. But as you said just then, because of the fibrosis, it's definitely much more safe. However, depending on how much you burn, even though superficial, or it might seem superficial, we do often clip those areas. Yes.
Yeah. Okay.
But we do need the NBI as well to detect flat recurrences. So these are the images are quite small. This is a bit better. Nice images of scars and their high definition white light and NBI, and what we can see here for everybody who's familiar with scars is actually you can see that the fold here is not nicely circular anymore. So this is because of fibrosis due to the scar formation. This is not just a line. Sometimes you really have a linear scar. This one is definitely more round and will require inspection, careful inspection. Also, really look behind the folds, and don't forget that the scar might be actually larger than you would think at first glance. Here at the anorectal junction, you can see very nice, very large scar under white light and NBI. Here again, and again, very nice, all without recurrence, all very nicely seen with the both techniques. But here, it's actually, you don't even need glasses to see this one. Very, very big recurrence. But this one's much more subtle. If you look at the left-hand side, white light will actually really not reveal the recurrence very easily. But if you look under NBI, you can really see there's a tiny focus of recurrence right here that you will want to remove. Here again, rather elevated recurrence, not.
But it's true that this kind of interventions, they interrupt the way we are following our patients. So they sometimes come to the consultation and they say that they have to come repetitively a lot for these colonoscopies, and so it's true that I don't really know if you start following up a scar that's like every 6 months, or first at 6 months and then a second one. Yes. After
18. Yeah. So we do definitely, when there is no recurrence at first surveillance, you do extend the interval. But you make the point there. The patients really find it a burden, don't they? Yeah.
Okay. So I got the sign that we need to end this discussion here, and I would like to invite Dr. Schoonjans in the studio.
While Lopke is preparing for a live endoscopy, I'm going to share some videos with you of scar assessments.
Okay.
And quiz. Yeah, a bit of a quiz. And it's just...
Can I ask another question while you're
please.
Opening your videos? Because I know from the use of Vegas that you have something like buried glands. So it's a question to Rafa, I think. You can have like under the submucosa malignant tissue that under the mucosa malignant tissue that grows. Do you have something like that in the colon as well, or do you have it in IBD, for instance, and not in normal colon? Does it exist like a growth underneath the mucosa?
Personally, I haven't seen that yet. No. I think there may be a potential if you have not a complete central resection and you close the defect, then that could be an issue. No, I don't think it's not like in And even in esophagus, we don't
Yeah,
have
I
it
know
that
it's
often.
not that often in esophagus. I know it's not that often. It was a concern, but it exists.
No, we haven't seen it personally yet.